Okay, I think we'll try to get started. Good afternoon, everyone. My name is Trish Markus. I'm a partner in the Raleigh, North Carolina office of Nelson Mullins. And today we are bringing to you a webinar about the COVID-19 emergency and essentially a regulatory recap of what's been happening over the last several weeks. I would like to introduce to you my co-presenter, Lester Perling. He is a partner of Nelson Mullins in our Fort Lauderdale office. Lester is a nationally recognized expert in fraud and abuse matters, including the Stark Law and the Anti-Kickback Statute. Gabe Imperato, who was also scheduled to speak with us today, is not going to be able to join us, but Lester will cover Gabe's portion of the presentation later this afternoon. And so just briefly, Lester's going to discuss the Medicare Advance and Accelerated Payments and Stark Law waivers. I then will jump in on some telehealth, HIPAA, and other compliance and payment flexibilities. And Lester will conclude our discussion with some enforcement and compliance considerations related to the coronavirus. Before we begin, though, I just wanted to mention a couple of quick things, and if you'd move to the next slide, please. We have on our homepage a really nice resource devoted to coronavirus matters pertaining not just to the healthcare industry, but really to the effects on our entire economy. And so I would recommend that to your attention. The website is listed on our next slide. One of the things that is going to be important for you to know is that we have a lag in our slides, and so it may be that we are talking and you don't see the slides, and please bear with us. It's not that the person who's helping us with the slides has not moved them forward. It's simply that we're having a little bit of technical difficulty. Unfortunately, we probably aren't going to have time at the end for a question and answer session, but please feel free to email any questions you have to Amanda Miller. Her information is on this slide, and I believe also at the end. Then we have a couple of things coming up. On April 15th, we've got Webinar 5 in our COVID series on SLA and Americans with Disability Act considerations for remote workers as well as cybersecurity risks. On April 16th, we will feature a webinar about how COVID-19 is reshaping healthcare, and Ford Coles, who is an executive with the advisory board company, will be moderating that discussion. And finally, this PowerPoint and a recording of the presentation are both going to be emailed to those of you who are participating, and it also will be posted online. Next slide, please. And so with that, I would like to turn it over to Lester.
Thank you, Trish. Good afternoon, everybody. So as Trish said, I'm going to be talking about two issues: Medicare Advance / Accelerated Payments and Stark waivers. Next slide, please. And I'm going to start with the Medicare Advance Payment Program. So first, with regard to eligibility, the two top ones probably are pretty easy. The provider or supplier has to have billed Medicare within the last 180 days immediately prior to the date of signing the form and not be in bankruptcy. So probably those things are not going to be an issue for most of you. The next two potentially could be. So first, the provider supplier cannot be under active medical review. However, CMS has announced that it has suspended its medical review program temporarily pending the emergence from this emergency. There's no end date on that. And I do know clients of mine who have been under medical review have received individual letters telling them that the medical review has been suspended, and they may or may not pick it back up at a later date. So presumably that won't be an issue. But also, if you're under program integrity investigation, you would not qualify. What that generally is going to mean for most folks would be if you are under audit or investigation by the Unified Program Integrity Contractor. That would be a program integrity investigation. Whether it includes investigations by OIG or DOJ, is unclear exactly the scope of that phrase. But, if you're in one of those categories, I would apply. I would certainly be honest on the application form, make sure to the extent they ask any questions about that, you want to answer honestly. It doesn't hurt to apply and see if they approve you. The next eligibility point is not having any delinquent Medicare overpayments. So notice that's delinquent, not an overpayment. So for example, if you do have a pending overpayment matter that you're waiting for a qualified independent contractor reconsideration, for example, and so collection of your overpayment is pending that appeal decision, you would not have a delinquent overpayment. You would have an overpayment, but I don't think it would be delinquent. So I think you would still be eligible. Again, if you're not sure, you apply. Make sure you answer the application questions honestly and see what they do. So next slide. So I wanted to mention too, I'll mention it here, I meant to mention it at the beginning that, this really is an advance payment. This is not a loan, there's no interest. This is simply taking money that Medicare anticipates that it would pay you in the future and pay it to you now. And the implications of that are potentially a bit painful, and I'm going to get into that. So it's really, they're just taking the money that they think will belong to you anyway, giving it to you now, and you won't be getting it later, and I'll talk about that. So the amount that can be requested must be requested specifically by the provider. So the limit is 100% of Medicare payments for a 3-month period for most providers and suppliers, like medical practices, nursing facilities, home health agencies, DME suppliers. However, for most hospitals, the limit will be 100% for a 6-month period. And that includes acute care, children's, and certain cancer hospitals. For critical access hospitals, that goes up to 125% over a 6-month period. Now, since you have to request a specific amount, then, and when I've done this presentation other times, people have asked, well, what's 6 months? And I would just take the most recent 6 months and add up the total payments you've received and go with that. And so if you're an acute care hospital, that would be 100% of those payments. If that's let's say for some reason those 6 months are atypical and they're atypically low, you probably want to contact your Medicare administrative contractor and talk to them about that as to whether or not, what 6 months. You could maybe select a different 6-month period. But it's unclear. There's nothing that defines the 6 months and how you're supposed to calculate that in your request. Next slide, please. So how to request, simple enough. Each Medicare administrative contractor or MAC has a link on their website. They'll take you to the form. It's an online form. You do have to be enrolled to get into the system, just like you do most things when you're going onto the Medicare website. You need to make sure, as always, when you're completing a Medicare form, that you provide all requested information, because otherwise it's just going to delay the processing. And if something's not applicable or there's no answer to it, I would never leave it blank. I would put that NA or something. Make sure it's consistent with your existing enrollment file. So a good example of that is if you're a DME supplier and Medicare has you enrolled with an address of 100 Main Street, but since you enrolled, you moved to 200 Main Street, but you forgot to tell them. And on this form, assuming you have to include an address, you put 200 Main Street, that could cause you a significant problem, because that may have meant that you failed to change information during the required time frame and could lead to other consequences. So just be cognizant of that. Finally, the form has to be signed, which can be an electronic signature. At first, it was only a wet or ink signature. That recently changed. But it has to be by an authorized representative. So that's the individual, again, indicated in your enrollment file as the person who's authorized to sign documents on behalf of the provider or supplier. Next slide, please. So they're hoping to turn these around within 7 days, both review the request and issue the payment. Payments will be made in the same method as your regular payments, which are, for most of you, going to be electronic fund transfers. As of a couple of days ago, CMS said they've paid out about $34 billion of payments so far. And they also said that some hospitals were underpaid. They didn't send them the appropriate amount, and they're going to be sending supplemental payments. Next slide, please. So the next slide talks about, there we go, repayment, and this part is important. So repayment begins for all provider types 120 days after the issuance of the payment. For hospitals, it should be completed within a year, essentially the same amount of time that the advance is for. For others, it's 210 days. They get longer. So for medical practices and other types of Part A, Part B suppliers, it's 210 days. If you happen to be a Part A PIP hospital or periodic interim payment hospital, then the repayment is settled at the time of your cost report filing. Next slide, please. And here's what's important. And the way they're going to recoup or collect their money is through recouping all of your then current payments after the 120 days has expired. Or you can choose to pay it up front in a lump sum to avoid a recoupment if you're able to do that. Right now, there's no other repayment method permitted. I called a couple of days ago to see about the possibility of a long-term payment plan or something, and was told at this time the answer would be no to that request. So as you see there, I've highlighted the fact that during that repayment period, your cash flow stops until the Medicare program has recouped what it has sent to you as an advance. So remember, it's an advance, and that's the advance money, the money they're not paying you. So that means you could get this extra money now, and if you don't plan for it without cash flow going forward, you may have a significant problem. You may want to think of this as a very short-term sort of financial and cash infusion until you are able to get some other sort of loan under one of the other many programs that are now provided for, so that you're then able to withstand the recoupment of this loan. So this is something before you do it. It sounds like a great program and it's a no-brainer and I'm just going to do it and this will be great. It has a very potential problematic time bomb that will start 120 days after you get your money. If they haven't collected the money, if Medicare hasn't recouped the money, they will send a collection notice. Essentially, I'm not sure what it will happen then. If you can enter into a long-term payment plan, if they're going to keep recouping, it's not very clear. But in any event, the recoupment starts 120 days after the payment of the money. So let's skip ahead to the Stark Law waivers. I think there's one more slide on this, but we'll go to Stark Law. Okay. So several days ago, beginning of last week now, actually, I guess, CMS issued some long-awaited waivers under the Stark Law. Now, the waiver, this waiver and the waivers, some of the waivers that Trish are going to talk about, are called 1135 waivers, and they're called that because they're provided for under Section 1135 of the Social Security Act. Next slide. And in order to grant waivers, there's two prerequisites that the Secretary has to meet, both of which have been met. They're listed there. I'm not going to talk about them. You can read them. Just know that they have been met, and so that now is what has allowed the Secretary and its designees through CMS to issue the waivers. So next slide. So these waivers are referred to as blanket waivers, which is a little bit of an unfortunate term. The reason they're calling them blanket waivers is because they apply to everybody. And as opposed to individual waivers, because there is a provision, CMS will accept requests for any type of individual waiver, really, whether it's the Stark Law or not. But But for purposes of the Stark Law, they will accept individualized Stark Law waivers. And so the reason they use the term blanket is because to differentiate them from the individually requested waivers. But be very aware that these waivers only apply under limited circumstances. They're not like just a free-for-all, and I'll talk about that more in a minute. So the waivers can be revised from time to time. If they are revised, it'll be on a prospective basis only. The revisions won't be retroactive. There could be more blanket waivers issued. The waiver is limited to the circumstances described in the waiver, and all providers have to satisfy all conditions in order to rely on it. That's important. It isn't like, oh, well, this is close. It's not exactly what's described, so I'll go ahead and do it. That's going to be a problem. And I'll talk about that probably a little bit later. Well, I'll talk about it now. So, keep in mind that the Stark Law is a strict liability statute, meaning if you violate it, it doesn't matter whether you did it by accident or not. If you violated it, you're potentially liable. So if you think that you're close enough to a waiver to count, you're not. That doesn't work. You have to be within the waiver, and it has to be for, as I'll talk about in a minute, a COVID-related purpose, and we'll talk about what those are. If you're outside, while CMS may not go after you, you're certainly at risk for whistleblowers going after you, because I think professional whistleblowers, if you'll pardon the term, will be watching because there'll be some opportunities. If you're within the waiver, CMS will pay claims for DHS that it otherwise would not have paid. Next slide. So if you're relying on a waiver, it's important that you maintain records that are available upon request that document your use of the waiver and the circumstances of the waiver. You may need that to defend yourself later, even in a false claims case. So it's really important to maintain that documentation, because a year or 2 years from now, either you're going to forget, or whoever was responsible for it will no longer be with the organization. So that's important. Also, if you don't need to rely on a waiver, don't act like you are. Don't document that you're relying on a waiver. It may just fit within an exception, and you're better off just fitting within an exception, because those aren't time limited. They're not limited to COVID-related purposes. I had a client the other day, a hospital that was trying to fit itself in the waiver, and after asking him a few questions, I realized they'd fit an exception without worrying about the waiver. So don't try to fit in it if you don't need to. Next slide. So the waivers are effective March 1, and you cannot rely on them after the expiration of the Secretary's authority to grant waivers. When that will be, right now, we don't know, but that's something you're going to have to watch for. So if you're in a non-compliant relationship and relying on a waiver, that relationship has to end as of whatever date that turns out to be. So you've got to really monitor it carefully. It's another reason not to rely on a waiver if you don't have to. Next slide. So again, the blanket waivers, as I mentioned, only apply to referrals that are related to the public health emergency, that is COVID-19 outbreak in the United States. So, what related means is left somewhat to the imagination. In the fact sheet issued by CMS, they provide a whole lot of examples that are quite helpful, but they're not the entirety of the universe. But you have to make sure it's limited. So, if you're looking to rent space to a plastic surgeon who has nothing to do with treating COVID-19 patients, and you say, oh, well, during this emergency, I'll cut your rent in half, but after it's over, you'll have to pay what the normal rent would be. That doesn't work. That's not probably a COVID-19 purpose. So be very cognizant of that, and because you could be outside a waiver and be vulnerable. And the waivers only apply to these two types of financial relationships. There are others, for example, certain types of indirect financial relationships to which they don't apply. They only apply to these two types, to arrangements with a physician or a physician organization or the immediate family member of the physician. Next slide. So the next slide goes into what a COVID-19 purpose is. I'm not going to read all these to you. You'll get the PowerPoint, or you can also see them in the CMS fact sheet, which if you don't have it or don't know where to get it, we can send it to you, or it's available on CMS's website. So these are the COVID-19 purposes. So you have to make sure you are within one of these purposes in order to rely on a waiver. Next slide. So here's the purposes of the waiver. Again, I won't read these to you. The idea is just to make sure medical services are available both to the community generally and also for COVID-19. Next slide. There are 18 waivers. I didn't list them all. Again, they're in the fact sheet. So these are the categories of the waivers. So one group of them relates to compensation that is either above or below fair market value, and otherwise the compensation would have to be at fair market value, such as the rental of office space. Compensation that exceeds remuneration limits, such as medical staff incidental benefits. There's an annual dollar limit, so if it exceeds that, that would be waived. Loan terms not available from a lender. Generally, if a DHS entity like a hospital is loaning money to a physician, and the loan terms are not commercially reasonable, they're not something that would be available from a lender, that's going to be a problem. The same or centralized building requirement is waived. I don't have time to get into that, but if you're familiar with the in-office ancillary services or group practice exception under START, you know what that is, but if you have questions about it, we can answer it. And then there's no writing or signature, but the relationship otherwise qualifies for a waiver, then it will be protected under the waiver. So that was a quick overview of the waivers. It's going to be a whole lot more complicated, but I wanted you to be aware of a couple key points. But I would be really careful if you're relying on a waiver, one, to make sure it fits, and two, to document that analysis in some form or fashion. So now I will turn it back over to Trish.
Thank you so much, Lester, for that great information. I'm going to talk about a few topics and have a lot to cover in not very much time, so I may be doing a little skipping myself. But I'm going to start out with telehealth, then talk about some HIPAA, and finally some other compliance and payment flexibilities that we've seen over the last few weeks. Next slide, please. Actually, 2 slides on. So first, as Lester has been talking about, there were a number of blanket waivers that were issued. They were intended to prevent gaps in access to care for Medicare beneficiaries, at least those blanket waivers issued by CMS. CMS had a specific Section 1135 waiver for telehealth use. And in addition, we have some information about the CARES Act interim final rule, which relative to telehealth added a number of services to the list of telehealth services that Medicare is going to pay for. And the interim final rule also provided that certain providers who don't necessarily typically provide services through telehealth can do so during the public health emergency for purposes of trying to keep everyone safe and provide appropriate access to care for individuals who can't really go places because they're vulnerable. Next slide, please. So some of the Medicare telehealth flexibilities are, I think, helpful, and a big question which we don't have an answer to is whether after this period of the public health emergency, any of these flexibilities will continue. Obviously, based on the statements in the issuance of each of these waivers or rules, the answer to that, at least right now, is no. But one does wonder, depending on how things go over the period of the emergency, whether we'll have additional opportunities to expand telemedicine offerings. So in any event, for the time being, Medicare patients can get telehealth visits at home, which is a big deal. Used to be they had to go to their doctor's office or be in a hospital. They also can be eligible for Medicare payment for those services if they live in an urban area. As most of you know, previously they had to be in a rural setting. That is effective starting as of March 6th, and as I just noted, through the end of the coronavirus public health emergency. In addition, Medicare patients who are eligible for telehealth can be new patients, whereas previously they were only permitted to be established patients. There is payment parity now under Medicare. Individual providers and facilities get paid the same for services provided by telehealth as they do for in-person visits. And perhaps I don't want to say shockingly, but somewhat surprisingly, and I think to the credit of different government agencies, providers are now able to use smartphones for telehealth visits. I should say providers and beneficiaries, because providers, many of them already have telehealth platforms, but most patients do not. And if they're in their homes, how else are they going to be able to access telehealth services? To be eligible for Medicare payment, though, the smartphones have to have interactive audio and video capabilities. I say that, but that's only for a specific or a discrete telehealth service. There are a couple of other Medicare services, including shorter visits called virtual check-ins, and then e-visits, which can be done through a patient portal. And so those don't require the audio-visual component. Next slide, please. I think I just mentioned, I'm looking here, going on with additional Medicare telehealth flexibilities, and that's right, that these can be new patients. So a patient doesn't have to have an established physician-patient relationship before the public health emergency. HHS has indicated that it is not going to conduct audits during the public health emergency to ensure that a prior relationship existed. So that should be of some comfort. Another important thing to know during the emergency is that providers may waive or reduce patient coinsurance requirements. The Office of Inspector General has added this flexibility to enable more patients to seek and obtain care during the coronavirus emergency. Of course, typically, routine waiver or reduction of copays would not be permitted because it would violate the anti-kickback statute and the civil money penalty laws. Next slide, please. So let's move on for just a second to HIPAA. We're going to come back to HIPAA later and talk about telehealth-related things now. But HIPAA, the Office for Civil Rights actually had a key role in enabling additional use of telehealth because it was the agency that essentially said, we realize that we've required certain secure platforms to be used, and many times those secure platforms are not able to be used on smartphones. And so essentially the Office for Civil Rights has enabled the use of smartphones by saying that FaceTime and Skype and other everyday communications technologies that are similar to that will be permitted to be used during the emergency, and the use of those technologies will not subject the covered entities who are using them to HIPAA enforcement. OCR did caution, though, that this doesn't mean that providers and patients can use so-called public-facing video communication applications, which include Facebook Live, TikTok, and some others that, sadly, because I'm old, I've never heard of. The Office for Civil Rights also noted that while it does recommend that providers both identify HIPAA-compliant telehealth vendors and also enter into business associate agreements with those vendors, OCR is not going to impose penalties for failing to have a BAA in place or for other non-compliance with HIPAA requirements, I guess related to this, really related to the use of these technologies during the public health emergency. Next slide, please. The DEA has also jumped into the fray, so to speak, and provided some flexibility in the area of telehealth. Due to the public health emergency, now DEA registered clinicians can issue controlled substance prescriptions for new patients using telehealth technologies. These technologies need to be audiovisual and real-time, so this is not a case where phone is usable, but phone alone, audio alone is usable. But nonetheless, this is really somewhat remarkable because for years, the Ryan-Haight Act has generally prohibited clinicians from prescribing these controlled substances to patients with whom they had not previously had an in-person meeting or examination. Next slide, please. In addition, the DEA and SAMHSA together have provided some flexibilities for prescribers of both buprenorphine and methadone, which are typically used to treat patients who have opioid use disorder. On the DEA side, starting on March 1st and effective until the end of the emergency or an earlier date if one is specified by the DEA, practitioners who are authorized to prescribe buprenorphine can do so for new and existing patients who have an opioid use disorder, and they can prescribe this by phone without an initial in-person or telehealth examination. SAMHSA, which is the Substance Abuse Mental Health Services Administration, also has indicated as of March 19th that outpatient opioid treatment programs, or OTPs, will be exempt during the public health emergency from the requirement to perform in-person exams of new patients who are going to be treated with buprenorphine, so long as the physician determines that he or she can make an appropriate evaluation of the patient through either a telemedicine application or, if the patient doesn't have a smartphone, simply through an audio call. It's important to note here, though, that this exemption does not apply to new patients of OTPs who are being treated with methadone. Those patients have to have an in-person exam before treatment can begin. And the difference really relates to the fact that with methadone, patients on methadone typically may have more significant relapse likelihood and really do need to be seen and evaluated on a daily basis, at least at the commencement of treatment. It's also important to note, though, that existing OTP patients who are being treated with methadone may be treated by telehealth or phone if, in the physician's judgment, that patient is in a good place in his or her recovery. And finally, practitioners who are not in OTPs, but clinicians, physicians, clinics who have Data 2000 waivers are permitted to treat both new and existing patients with buprenorphine, again, either by telehealth or phone if needed. Next slide, please. So let's move on for a couple of minutes to state telehealth flexibilities. It's been really interesting, and I'm sure some of you have been observing this as well, to see all of the new executive orders and medical board or nursing board or pharmacy board issuances that have been coming out over the last 3 to 4 weeks. Governors, Medicaid agencies, licensing boards, all of these types of agencies are issuing waivers of different regulations so that healthcare providers can serve more individuals during the emergency, and in particular through the increasing the use of telehealth, recognizing the need to really separate individuals and try to limit the possibility of infection. So as of April 8th, yesterday, at least 31 states had some kind of waiver in place related to the provision of telehealth, and you may already know this, but we've listed here the link to the Federation of State Medical Boards. They really have an outstanding group of resources related to the COVID emergency. Next slide, please. So here we have listed a few different flexibilities that states have implemented. I'm going to go through these pretty quickly. I tried to focus on states where, in which Nelson Mullins has a fairly significant healthcare practice, and there are others, but frankly, these were the ones that I was already aware of and could get down fairly quickly. So, and there are some similarities, as you will see. In Florida, certain practitioners who hold an unrestricted license in another state are permitted to furnish telehealth services to Florida individuals for a period of 30 days, unless that order is extended. We are close to April 16th. My guess is it will be extended, but we will have to wait and see. That same order also allows those same types of providers who are controlled substance prescribing practitioners under Florida law to renew controlled substance prescriptions by telehealth, but it has to be with an existing patient, and it has to be for the treatment of chronic malignant pain. So that's a fairly limited expansion in Florida. In Georgia, same type of waiver announced. Previously unlicensed providers who are wishing to treat Georgia patients can obtain emergency practice permits, for which they would have to apply through the Georgia Composite Medical Board. Those permits last for up to 90 days or until the end of the public health emergency. Also in Georgia, DEA registered practitioners can prescribe controlled substances for new patients. Next slide, please. In Maryland, they also have waived in-state licensure requirements for out-of-state licensees. And interestingly, there has been an order for the Department of Health to pay both for synchronous, which is the real-time audio-visual communication technology that most of us think of when we think of telehealth, but also to pay for asynchronous telehealth services. That often is an example of an asynchronous service is when a patient takes a picture of a wound and forwards it to his or her dermatologist. And so both of those types of services will be paid for whether the patients are present in a clinic or if they're at home or in some other place, so long as the service is covered by Maryland Medicaid and furnished by a Medicaid participating provider. And then in North Carolina, we've had a couple of interesting developments along these lines. We had an executive order issued by the governor early in March, which waived temporarily North Carolina's license requirements for healthcare providers licensed in another state or territory. Interestingly, we just had another executive order yesterday, which I think is somewhat significant for a number of reasons, but related to telehealth. It essentially provides immunity from civil liability for those providing telehealth services, except in cases of willful misconduct, gross negligence, or bad faith. And my guess is that some other states are looking into doing that because of concerns about whether liability insurance covers telehealth services when a clinician is not licensed to provide those services in a particular state. One other thing of note in North Carolina is that it seems that all payers, both government and private, are covering all telehealth services, at least through audio-visual means, not necessarily the store and forward kind. And they're also offering payment parity, and they do not have prior authorization or originating site or distant site requirements. So once again, patients can be in their homes, and so can clinicians for that matter. Next slide, please. And then finally, in South Carolina, the South Carolina Medical Board, or Board of Medical Examiners, also has temporarily waived licensing requirements for certain providers who have licenses in other states, and if their services are determined to be necessary by the South Carolina Department of Health and Environmental Control. the board has advised that that means that those persons can treat South Carolina residents in person or by telehealth to screen or treat patients for the coronavirus. It's possible that additional flexibilities will be permitted in South Carolina, and to the extent that's the case, we will update folks through our coronavirus offerings on our website. Next slide, please. So briefly, I think some open questions here on telehealth include informed consent. I've had several questions about this. Do we have to get informed consent? How are we supposed to document this if everybody's using a phone? I think the practical answer is that in most cases, especially if you've seen the patient before, they've probably provided a consent form. If you're not able to get something in writing from them, it makes sense for the provider to verbally explain the risks of telehealth technologies and get the patient's verbal consent to receiving care that way, and then document that in the record. And that could happen during the telehealth visit. Same thing goes for whether providers have to maintain a contemporaneous medical record if they are not linked to their electronic health record. And we can quibble about the definition of contemporaneous. I think, generally speaking, medical records do need to be maintained, but my understanding is that some waivers and orders are giving some flexibility with how quickly information needs to be submitted and provided into the medical record, recognizing that folks are working on the fly here. A third issue that I've had come up is the concern that some malpractice insurance carriers do not cover telehealth services where the practitioner doesn't actually have a license in that state, irrespective of whether the state has permitted an out-of-state licensee to perform such services. I am aware that in North Carolina, the physician malpractice insurers that I know of all are covering these services, but that doesn't mean that that is a common practice, and so that's another thing for lawyers and providers to be aware of as we're advising folks about how to address legal issues related to telemedicine during the public health emergency. And finally, even though North Carolina has pretty good private insurance company payment for telehealth and parity in payment, you get paid the same for a telehealth visit as you would for an in-person visit. This is not the case in all states. It's probably not the blanket case in North Carolina, although what I've seen indicates there's good parity. So it's going to be important for us as we move forward to think about how important it is for our clinicians and our facilities to get paid for these services, even if they're using technologies that are not traditional ones. Next slide, please. So we're going to move on quickly to HIPAA waivers and guidance that's been issued in the last several weeks. The first one, next slide, please. The first one I'm not really going to spend a lot of time on because for the most part, it pertains to hospitals and it also is only a 72-hour waiver. So once a hospital has instituted its disaster protocol for this emergency, OCR will waive HIPAA sanctions and penalties for the following the items listed here on this slide, which, frankly, in my view, it makes sense for some of these perhaps to be waived more broadly during an emergency of this type, but no one consulted me, and I understand that I don't know everything that goes on in the halls of government. Next slide, please. More specific and more recent, I think really more specific to the COVID-19 emergency, was this waiver issued last week that indicates until the Office for Civil Rights issues a notice that it's no longer going to exercise its enforcement discretion, OCR is going to waive HIPAA sanctions and penalties if you have a business associate who is using and disclosing patient information to a public health or an emergency oversight authority, or if the business associate is performing data analytics using its covered entity clients, PHI, in order to make disclosures to those officials. Where the business associate agreements that the business associates have with their covered entities don't specifically permit those uses and disclosures. And let's be honest, I have not seen any really BAAs that include that language. But one of the OCR general requirements is business associates can only perform those functions or services that are spelled out in their business associate agreement or as permitted by law. So OCR is clarifying that it's not going to take enforcement action against either covered entities or business associates who participate in these types of activities. However, the business associate does have to make these types of disclosures in good faith. It has to be for purposes of public health or health oversight activities, as those are defined in the privacy rule. And the BA also has to inform the covered entity within 10 days after it has used or disclosed the PHI or after that use or disclosure has started. Next slide, please. We have a new waiver that was published today that indicates that as of March 13th and for the remainder of the COVID-19 public health emergency, OCR will also exercise its enforcement discretion and not impose penalties for noncompliance with HIPAA by covered entities or business associates who are in good faith participating in operating what are called community-based collection and testing sites. Many of you are probably aware that hospitals, other facilities, labs, pharmacies are setting up these sites outdoors, in part to try to make a safer environment in emergency departments and also to try to provide additional places where individuals can go get tested. Although OCR is not going to implement enforcement if such good faith compliance or operation rather occurs, it is encouraging folks who are involved in these sites to do things that would protect privacy and security, like setting up canopies or opaque barriers, trying to control foot traffic so that there's adequate distancing between people and cars, establishing buffer zones and posting signs that would tell the media and members of the public not to film, and also posting notice of privacy practices or other information about how to find those notices online. Next slide, please. And finally, very briefly, it's really important to remember, despite these waivers, that the minimum necessary standard has to be observed. And so, except for providing PHI for purposes of treatment or not as required by law, or to the individual, entities have to make reasonable efforts to comply with minimum necessary. And so this slide lists all the situations where the minimum necessary standard still applies. And there is some guidance that's on our website related to these different disclosures. Next slide, please. And one more, please. Thank you. So the CARES Act interim final rule, this was a lightning fast review by me, and this will be a lightning fast discussion of these issues. But it's interesting to me that that CMS provided these additional payment flexibilities in the interim final rule. I guess I shouldn't say it's interesting to me. This is coming, of course, from the CARES Act. What is interesting, though, is that this interim final rule was issued on March 31st, but it's effective beginning on March 1st. It's retroactive. You don't see that very often in our world. And basically, the interim final rule has changed Medicare payment rules during the emergency so that physicians and facilities can use remote technologies to increase access to testing and access to healthcare, and do so in a way that will avoid and limit exposure for everyone. Next slide, please. Many of these flexibilities relate to telehealth. And so one of them is that the facility fee for telehealth services has essentially been made to match what what you would receive if you were providing the service in person. So that's the place of service code that you're supposed to list when you are providing a service to a patient using telehealth. You're also to add CPT modifier 95 to all telehealth service claim lines. Next slide, please. I will not list these, but just for your reference, there were a bunch, I think I read somewhere about 80 different services that were added to the list of Medicare telehealth services. And so I'll leave these for your future and further review. Next slide, please. Also, Medicare has broadened the situations under which remote patient monitoring, for example, evaluating patient images or the virtual check-ins that we talked about a little earlier, are paid for. And they're also available, that type of monitoring is now being paid for both new and established patients. Direct supervision now can be provided through interactive telehealth modalities. So if the clinician is isolating and the patient is with a provider at a clinic or a hospital, the physician who is remote can supervise the provision of the services over a telemedicine connection. There's a new definition of homebound specific to the coronavirus, namely if a physician certifies it's medically contraindicated for a patient to leave the home. And home health agencies also can provide telehealth services as part of the patient's plan of care if the service doesn't replace required visits set forth in the plan of care. And hospice also has some new flexibility and ability to use telehealth for the provision of certain services. Next slide, please. And finally, just a couple of additional points here. Outpatient treatment programs or opioid treatment programs are permitted during the emergency to provide the therapy and counseling portions of their weekly Medicare bundled services by audio-only calls if the patients don't have access to audio-visual calls. Medicare just started paying for OTP services in January, and so now they're offering this flexibility, which harkens back to the SAMHSA and DEA flexibilities pertaining to audio only. In addition, remote patient monitoring services where a clinician receives uploaded data about a patient's weight, blood pressure, O2 saturation, etc., now can be provided to both new and established patients. And rather than getting consent for these more frequently, as previously required, consent for these types of services to be received remotely can be obtained once annually, at least during the emergency. And last, physicians can base their E&M coding for telehealth visits during the emergency either on the amount of time that's spent with the patient along with other time associated with that E&M service on the date of service, or in accordance with the physician's level of complexity in the medical decision-making. So, sorry for the real quick rundown, but I'm going to turn this back over to Lester to talk about enforcement and compliance concerns.
Thank you, Trish. So just got a couple minutes left, so just going to hit some highlights here. Department of Justice is got significant concern about fraud related to COVID-19. Anytime the government throws a lot of money at a problem, the folks who there's plenty of folks who want to take advantage of that. We see it when there's natural disasters, and it's already, according to the Department of Justice, occurring here. There's any number of scams that have already developed. There's going to be fraudulent applications for loans, all kinds of things. So the DOJ has actually established a COVID fraud coordinator in each of its U.S. Attorney's office around the country. So that's how much emphasis they're giving it. That's a pretty significant move. In addition, they've established in the District of New Jersey, it will have national responsibility for investigation and enforcement of issues related to hoarding and price gouging. And why they picked New Jersey, I don't know, but I suppose there's any number of New Jersey jokes that one could say in response to that, but I won't. Another indicator of how important this is to them is we're aware, because some of our clients who happen to be cooperating witnesses in criminal investigations completely unrelated to COVID, we're being told, look, if your client has any information about any COVID-related fraud, price gouging, et cetera, and they want cooperation credit, let us know. I mean, that's awfully extraordinary, at least in my experience. So that they're laser focused on these issues because they understand the potential risk. Federal courts, of course, are delaying certain proceedings like grand jury proceedings. The enforcement agencies, DOJ, are looking for alternative ways. They can't issue grand jury subpoenas anymore because there's no sitting grand jury to approve it. So they're using other types of subpoena and civil investigative demand authorities. They have concerns about statute of limitations, things like that they're working on individually with individual courts, but also through legislation in Congress. The Office of Inspector General has just recently issued a policy or a statement that during the COVID emergency, it will not seek sanctions under the anti-kickback statute for relationships that might otherwise violate the anti-kickback statute, but fit within one of the first 11 Stark Law blanket waivers. Often when you're outside of the Stark Law exception, for example, you're paying more than fair market value to a physician, that could be a violation of the kickback statute. And so OIG has said they will not seek administrative remedies in those circumstances, but it only applies to the waivers 1 through 11. If you're looking at the list, remember there are 18. So 12 through 18 are not protected in that way. Also, keep in mind the OIG does not speak for the Department of Justice. So this policy doesn't technically preclude the DOJ from pursuing either a criminal case or a civil case under the False Claims Act, but I think that would be very, very unlikely. Of course, the OIG also doesn't speak for whistleblowers. And as to sort of highlight what I mentioned previously when I was speaking, if providers take advantage, for example, of the Stark blanket waivers, the OIG's discretion not to enforce their administrative penalties under the kickback statute in those circumstances, other waivers that occur, that doesn't mean there won't be enforcement. And again, the biggest threat as was before the public health emergency and will be again after it, will be whistleblowers who can bring a complaint. So it's important to remain compliant, keep your eye on the ball, because even if the government is more lenient, that doesn't mean the whistleblower community is going to be. So documentation is always as important. When there's a waiver, make sure you're compliant with it, and make sure you document your compliance, how you're compliant, why it's justified under the particular circumstances of the waiver, all those things that make kind of common sense in the application of these many, many waivers. And be careful about them. Like, Trish talked about the DEA waiver of requiring an in-person visit for the prescription of a controlled substance for a new patient. And she mentioned Florida had waived some in-person visit prescribing requirements, but Florida did not waive that requirement for initial visits. So there's discrepancies between the federal waivers at times and the state waivers. For example, Florida did not waive its ability to enforce any of its kickback laws. They may choose not to, but you got to really be careful and look both at state and federal law and understand what the risks are when you're taking some sort of unusual action. You got to do what you got to do, but just document why you're doing it and exactly what you're doing. So we are about 1 minute over, so I will conclude my remarks then. Thanks everyone for attending. And again, if you have any questions, you can email either Amanda or directly email Trish or I. I think our email addresses are in the PowerPoints.
Yeah, thank you so much, everyone. I just wanted to say we really appreciate the work of our healthcare provider clients and friends and attorneys who assist them, and everyone stay safe out there, and we'll talk to you soon.